Hello everybody. This is 5 o'clock and we would like to have our master class of the month. Today we are going to talk about MES, microembolus signal and emboli detection. But before I start my lecture, I just would like to advertise my TCD master class for you. We're going to have a virtual and also a hands-on training on June 11th. Please visit our website. So far I only have 10 people registered. If we are not making it to 50, we're just going to cancel it. So please go ahead and register and join us. This is the website, and I just would like to show you quickly a program. We're going to start 8 o'clock, and we have international speakers joining us via Zoom. After the first few lectures, we'll have the afternoon reserved for the hands-on training, and we're going to have 6 different groups, 6 different sonographers, and we're going to scan on individuals, volunteers with pathology, so not healthy ones. So today we're going to talk about emboli detection, and the motivation was the previous month. Someone asked a nice question, do we see microembolus signal somewhere else? This is so fresh. I just want to point out today's date, so you can't get anything as fresh as today's scan. Today's scan was done, and this is a right popliteal vein. And what you see in the popliteal vein, there's an embolus 1, 2, 3, 4, 5, and maybe more in the background. And I don't think we really pay attention when we see that, and unfortunately when we have our duplex machines are really not recording the sound. So I cannot really play you back that in the background do you hear anything, because for the embolus detection we really need to hear a distinct sound of that microembolus signal. So as of today's case, I would like to point out that these are again randomly appearing signals in the waveform, and this is a venous waveform as well. So the idea is, excuse me, the idea is that you have your ultrasound reflecting on your red blood cells, and this is the red blood cell speed give you these waveforms, and if anything else traveling in that red blood cell stream, you're going to recognize with these high intensity transient signals. And these high intensity transient signals, again, they're traveling in the bloodstream. You can see what the speed is. So the speed is about 20 centimeter per second. Here is a slower one. Maybe this is only traveling 10. Hard to make assumptions. We wish we can size them. We think that this is the heavy piece, maybe a little bit bigger piece. The pieces are traveling faster, maybe lighter. But again, not much confirmation we can see about them. Here's a little bit older case, and this is actually the interesting one when you see lots of microembolus signal, lots of MES in the waveform of the carotid. And I would like to point out the scan is done at 9 o'clock, and the only confirmation is that you see the scan was done 9 o'clock, and you're suspicious what are these microembolus signal doing on my carotid ultrasound. And my first question immediately was, is this patient had a echo done? And yes. So this is 15 minutes prior to my carotid. There was an echo contrast injected, and these are the echo confirming that Lumison was injected, and this is where the injection is again 50 minutes later, that it's obviously going to be there. And it's very interesting, when we went to the left side, on the left side I did not see that. So again, it looks like there's a 15 or 30 minutes interval when these microembolus signal are going to disappear, and all these gaseous bubbles, they were gone. Purposely, we are injecting a contrast agent when we would like to see the middle cerebral artery better on our TCD. This is I had to visit my friends in Denmark because, again, the indication for the intracranial circulation is not there yet. So I hope that the companies will go into reach indication not just for the liver and heart, but hopefully for the brain. So that's the better visualization. If I wouldn't have this contrast, I wouldn't be able to see the stenosis. So after, and again, let's check out the time. I blocked the time on this one. But you see that here is a few minutes later, they're still visualizing the middle cerebral artery, but on the same depth. These are the few bubbles. They are not giving me the stenotic signals anymore. So this is the MCA, this is the PCA, P2, this is the ACA, these are contralateral PCAs. So you can visualize all the intracranial vessels with a little bit of contrast. And this is the other beauty. Here's a definitive was injected for the heart, and while it was injecting for the heart, we're studying the brain. So again, the injection, what you use for the heart, you can big bag and you can do the brain ultrasound while you're doing that. And what you see here is that without contrast, you see the middle cerebral artery signal only between 60 to 70. Suddenly, when a contrast arrived, the entire hemisphere is just lights up. So all these reflections, you're able to scan and see the velocity throughout the entire middle cerebral artery. You can see the ACA, which previously was not visualized, and also you can see the contralateral ACA. So you're able to see measurement, and I think that's a beautiful example that here's your MCA. You only see the MCA velocity. I am at the MCA-ACA bifurcation, and I started to see even the ACA here. So that is the beautiful contrast, what your M mode is showing you, but also showing you what is the spectrum showing above, positive, and here's your negative signal here. One more beautiful example. Where is this microembolus signal is coming from? I hope this waveform is burned in everybody's brain, and this is what we see in pseudoaneurysms. And what you see here is that one microembolus signal is coming out of the sac. So again, just because it's flipped, the negative signal, the minus 100, that means this is negative. Despite Siemens haven't figured out which is positive, negative, don't be bothered that this is positive, but this is coming towards you, this is going away. Hopefully one day they will get a negative signal here. Here's a tiny negative signal, not much on this, so this is assumed positive. This may be the negative one. And this is why it tells you this is belong to the blue signal. This is going away from your probe, so that's why it's going out of your sac. But that's another confirmation that this is how tiny clots form in that PSA, and this is how they are coming out of the sac and get into the circulation. One of my first image we saw in the venous study, and this is again a femoral vein, there's a microembolus signal right there. And when we just quickly send it out to our vascular sonographer group, a few people quickly identified that, again, not just on TCD, but any other duplex, you're able to see that. Duplex is not ideal because your sample gate is small. Again, we are not paying attention because we're not recording. If you would hear bloop, 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 you will pick it up. So we just need to pay more attention and also decrease maybe the gain a little bit more to be able to see this microembolus signal. And again, one of my friend, Patrick Washko, quickly pointed out that he published what's on the venous side, what is this microemboli signal is maybe belong to a fat embolism when you have a bone fracture, and the bone fracture, this embolization gets into the venous system. And again, those are not friendly. Those are still gonna give you trouble in the circulation. And this is how you can see it on a B mode. And also you see a little bit of fat emboli almost like stuck to the wall. So this is how you can probably even pick it up here. So this is a really nice case report, so thank you for teaching that. What I wanted to talk about today, a little bit more, again, the TCD diagnostic code, the 93892. This is covering the emboli detection. So bilateral MCA recording, bilateral PCA recording. The vessel target is not named in the code, but the bilateral monitoring will be encouraged. So the definition. So size, macro embolus, we talk about 200 micron and more. So when we talk about microembolus signal, again, probably the TCD able to pick up anything from 10 micron. So the microembolus signal is going to be our 10 to 100 or 200, and the microembolus signal is going to be the 200 micron size. And this is where we are really want to focus today on the microembolus signal. And again, it's not a new thing. There was a consensus more than 20 years ago. This paper I found, I would like to thank for Dr. Rozumovsky pointing out this paper, 96. So sometimes not just a fresh paper, sometimes those nice old paper are going to teach us something that what sometimes we just don't understand, how these air emboli coming through the capillary system. And again, these are the nice air emboli in the dog capillaries while they were doing a cardiopulmonary bypass. And this is visually, you can really see how the microembolus signal dilates these capillaries, and this is how they coming through. Hopefully they are not stuck in those capillaries. And everybody wants to see the what is the evidence that the microembolus signal can do something bad to you. So just a reference paper from almost like the same year, same journal, shows you that in the moment you have microembolus signal, and it shows correlation with a deficit with the cardiopulmonary bypass surgeries, with again cognitive outcome. And you even if you want evidence, here's your p-value as well. But again, the number of emboli, it doesn't matter if it's air or solid. I think the total number of emboli really what we are looking for, and that looks like it's definitely correlated with outcomes more than 20 years ago. So it must be correlated outcomes even today. So what you see as a definition, and again, a microembolus signal was again classified and introduced as a spontaneous and random reappearing signal. And what we think is, again, at the moment, we just cannot differentiate truly between gaseous and solid particles. We're trying to, when we monitor surgeries, we try to see if it occurs during the injection, that we may call them more gaseous. When it occurs with a catheter moving and scraping the wall of the aorta or the carotids, then we call them solid. So we try to pair them with activities during the surgery, but as the TCD machine or none of the machine today can tell us this is gas, this is solid. So we'll give you some example of that in a moment. The spontaneous appearance, I think it's very important that here you see one simple and a single microembolus signal, which is on the tip of the waveform. That tells you that it's traveling fast. Barely you can see it on M mode, but what you see is that again, the aortic valve is closing here. So the aortic valve closure, almost like you see this shape here. I'm sorry. So you see the aortic valve closure notch is there. So this is why it's in the systole. And when it's in the systole, you can see it's traveling almost like 80 centimeters per second, almost still inside that speed limit, what you want to drive on a highway. So translate your centimeter per second to miles per hour, but it's there. So one of our interests is in our hospital is really monitor any of the heart valve procedures, but also after you implant a heart valve, do they embolize or not? Another huge interest in AFib embolization. So when you do an AFib embolization, like a mini MES procedure we monitored, there's not much embolization when you're burning the heart from outside, but when you have a AFib catheterization done and you're burning that AFib nodules, you will see way much more embolization, probably the highest emboli count when we do ablation. So these ablation procedures had even more emboli than even the TAVRs and even the CABs. The LVAD procedures we also monitor, and again, very important that you, for example, in the LVAD, you cannot see inside because it's covered with metal. So when you cannot see inside the metal, then you just kind of indirectly say that there's an embolus coming out from the LVAD, from the metal, that has to be inside. And with a little bit of TPA, you can resolve it. And again, a follow-up next day, there's no emboli. So that's when you see the treatment and you can confirm it. So again, during the surgeries, during these bone surgeries, you will encounter some fat embolism. During the right to left shunt, what we presented last month, we purposely injecting agitated saline, and this is again would tell us if you have a PFO or not. And there is an approach when with sonal thrombolysis, when you have a acute stroke setting, we added on the top of TPA a little bit of contrast agent, and that was the Tucson study. What you see on a microembol signal screen that it's always unilateral has to be moving in that waveform. It cannot be sitting on a zero line. If it's sitting on a zero line, the speed would be zero. So that's the idea. And why you see my waveforms are a little bit darker means that I decrease the gain, so you really appreciate this hyper intense signal a little bit better. Again, duration, it was saying a moment that the duration was less than 300 milliseconds. That is not true. So this is like 1 second. This is like way under 100 microsecond for sure. And again, we want to differentiate those artifacts when you're just tapping or there's a muscle movement may generate some sound near to the transducer. Nicolette machine had a really interesting approach that you can select 2 different depths. And with the 2 different depths, you can see that this embolus is traveling from here to there when you have only like a 10 millimeter distance between these 2 sampling depth. So here to there, definitely takes time to travel that 1 centimeter distance. You see the shape of the signature is changed. Maybe the shape in the waveform is really hard to tell there. But here's an easy how to differentiate with an artifact, because again, the artifact will appears at the same time of that 1 centimeter apart. So this is the travel. But the second thing that when you see the sound signature, and this is probably how your raw sound signature looks like when somebody trying to use your sound recognition. This is really so organized. Crescendo, decrescendo type is nice and symmetrical. This is what you can say that maybe this is a global shape, so maybe that is a sphere. If you have a little bit more elongated and more unorganized signature that is not as symmetrical, that would probably will be on a solid and a blood clots. Here, this is so unorganized, the waveforms are not moving the same symmetrical shape, and again is just not organized. You see that this is a little bit of weak signature, and this is when it's sitting on a zero line. So that's how by multi-depth sampling you're able to differentiate them. And here you go. This is one of the first, again, consensus with the Europeans, ESNCH, the European Society of Neuroscience and Cerebral Hemodynamics. We are trying to revise these, and hopefully within a year we'll have a new consensus of this microembolic signal definition. One of the key elements, and again, hopefully my physicist buddies will help me, this is definitely too long. This is probably for me less than 100, even less than 50 milliseconds. How long is that signature and the sound? The amplitude of 3 is a little bit not enough, because that will have so many artifacts that maybe we need to pop this up to 6 or 9. And again, the sound needs to be there. So it's very important that we need to see that. If you want to be part of it, please visit the ESNCH website, and you can still sign up if you're interested to part of these review groups. When you're looking at the data, so yes, 5 to 71%. It's really scary that this is the difference, how your protocol is written and what are the numbers you're using. So I'm really suspicious if someone would report that, oh, all my patients had microembolus signal. It's kind of impossible. We don't see that frequency. Usually with carotid stenosis, a spontaneous embolus number is somewhere in that 5% range in the total population. So it's not a frequent occurrence. So it's more on the lower side, and I will tell you more about the timing at the end of my talk. So the decibel, we already talked about it. Again, 6 and 9, it's more ideal, and we talk about the single and multi-gate one. But definitely the M mode has really changed our vision. And what I'm going to play you now, that I want you to pay attention to this gain. And thank you for Dr. Barato for these beautiful slides. He really went to next level to really show us if you're decreasing the gain. And again, decreasing the gain only here. So some of the machines cannot decrease the gain independently for the M mode from a spectrum. Well, that's the message for you guys. That's the reason why you want to keep your flow where the signal is, but you want to decrease the gain that you're able to differentiate and able to see it. So here, it's hard to pick it up. Here, it's easier to pick it up, and hopefully that will help the automatic embolus counting as well. At the moment, we are definitely not happy with the performance, how these machines are counting these emboli signal. When you have too many close to each other, they just even lost and they cannot count it. This is really easy to count. This gain is definitely low, low, low. This is why you don't see even a waveform. You want to see some waveform when you're counting these emboli. So I would say that not here, but put your gain somewhere here, and probably on the second one. That would be my ideal monitoring gain. And again, I'm sorry. So the multi-channel TCD screen is really revolutionized how many emboli we can detect. And again, here's a bilateral head frame and bilateral MC recording. This is my left side, this is my right side. Both of them is I'm trying to monitor them in the same depth. So you can really compare. The depth of 50 is my favorite. Why? Because only the middle cerebral artery is the only vessel is passing the 50. So if you go deeper, you can get PCA, you can get terminal ICA, some other vessels. But when you are monitoring at 50, you know that that's the middle cerebral artery, and you see that these emboli which are passing, they are going to the distal MCA. So this signal, for example, is getting into the perforators. So they are not traveling to the distal MCA all the way to the cortex, but maybe it's doing worse damage than that because it's going to plug in my perforators. And here, these are going all the way to the cortex, to the distal MCA. And the blue ones, these are going into the ACA. So this is where, when you just look at the single channel TCD, you had way much less embolization. We believe by the multi-depth and multi-channel TCD of the M mode is probably doubles the size and double the counts of the emboli, but at least 40% what is published. We see that many more microemboli. What you see here is just an example of something coming in the terminal ICA, goes into the MCA, came in an ICA, went to the ACA. So you see it a little bit coming into the MCA, but this is just a turn from the ICA and then goes into the ACA. That's just another cool example. But again, the power M mode is again this 33 channel. So 33 channel sampling, and the very important part of how you see the track of it, that you see the spectrum signature. Here's 2. These are the 2 signals. What you see in M mode belong to these 2 pieces. And what you see is this one a little bit slower. You see that the distance from here to here is a little bit bigger, and that distance is narrows down when you get to the distal MCA. Why? This guy is traveling slower. This guy is traveling faster. So this is a sharper upstroke. This is a little bit slower, so that's why it's a little bit deeper upstroke. Because I'm monitoring a depth of 50, this is why the ACAs, the blue signals, are not displayed in my spectrum. The spectrum only going to display those signals which are at the depth of 50. And again, in this signal, I'm recording only 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. But when you look at all that other signature, that's maybe I have another 10 going into the ACA. This is a weird one. This blue one doesn't have a tail coming in from MCA. This may be a representation that this signal is coming into the ECA and getting into the meningeal branches. That's why you have a blue signal front of that red signal. So when the blue signal doesn't have anything on the front of it, that means it did not come through this MCA. That blue signal is really coming from the ACA. So I think this is just fascinating when you just you have one signal screen, and I'm talking about it for 5 minutes, but that's the beauty, to really understand the speed, the numbers of the emboli, and again, where do they go? So you can pick up all that from that one signal. So this is again Mark Mooring first publication of 202 that he showed us, and he developed this M mode for us. And as of today, this is still the best M mode I can see. So thank you, Mark, for making our life so much easier to be able to see multiple depth, not just single depth TCD. And this is also Mark signature of here's my MCA, here's my ACA embolus, and you can see this is traveling in the red. It's right there. This is traveling in the blue. It's kind of going away from my probe. This is why this is more forward slash, this is backslash, and this is why you see it in the ACA and the negative signal. So definitely the path, you can differentiate and count how many emboli going into the MCA, how many going into the ACA, and then that total number was the total emboli count of the carotid. So again, not just in MCA-ACA, this is a beautiful signal in a vertebral basal system. So everything is blue. This is why you know that my probe is in the back. So I'm monitoring just the vertebral basal system pointing to the nose bridge. And this is how you see in a vertebral artery, this signal is traveling at the diastole. So slope is slow, gets into the basal at 80, speeds up. Almost looks like that from the end diastole gets into the systole because this has become so much faster. So this is, I would say, is really fascinating how it's jumping over. Looks like there's no border, no filter between the two heartbeat. So definitely one of these emboli can get from the end diastolic to the systole easily. So this is what you see, that the vertebral basilar, and also the signature with a little bit slower, a little bit thicker signature. While you get these faster signatures, see how it's slimming down? That's the weight loss of that microembolo signal. That's the only joke you're gonna get today. Oh no, there's one more joke. So because you are in Texas, you see a cow in the water, that's an artifact. This is how easy to differentiate a dolphin between a cow. So this is also Dr. Mooring slide, and seriously, it's my favorite. So when you have a jaw movement, tapping on the probe, something that is generating a sound, I'm tapping, I've generated sound, that would have a sound signature on my ultrasound, but here with a 0 speed. In a moment you have an embolus with a higher pitch, bloop, give you that signature, traveling in diastole. Here's your MCA signal for that. And again, it's a beautiful computer algorithm. If it's a not moving particle sitting on a 0 line, have multiple depth deleting that signature so you don't pay attention to them, and try to remain black instead of nice and bright and white, so that high intensity signal doesn't bother you. When you see this black, you know that this is just an artifact from a 0 speed something on your spectrum. Just a reminder, if you haven't heard about it, June 11, we'll have our TCD Master Class, and at the end of my talk, we'll play our advertisement for you. So here is a beautiful signal, bilateral monitoring, and these are just cutting artifacts. So again, sometimes you don't see what's in the waveform. Sometimes you need to really look hard where you see those emboli. And this was one approach by DWL, try to use 2 different frequency, a 2 and a 2.5 megahertz. But again, as you see, the signature of a air or a solid is crossing. So there's certain part when you cannot really differentiate them. And also the artifact rejection was 50%, didn't want to even differentiate when we use it for carotid stenting. When you know that you're injecting solid particles 50 or 80 micron size, beautifully, you can see it in one certain depth. And this is where you see that when you're injecting air, these bubbles are different size. So you really can count them, but there's definitely in a range of 15 to 25 micron. So what we try to use is, again, try to use 2 probes on the same side. So that was our fancy way of trying to see that if I'm placing one probe proximal to my filter and one distal to my filter, I wanted to see how many emboli the filter going to filter out. And this with the carotid stenting, you will see that these are the signals from the submandibular. This is why it's blue, because it's going away from your signal. These signals in the middle subartery, that's why it's red. So the different counts between them, that will tell you that it's only 20% of these emboli really filtered out by these baskets. What you see here is also, you see the delay. How long does it take from a submandibular bubbles to get up to the brain? I just have a better example here, that this is the bubble from a submandibular probe, arrives to the brain, goes into the ACA. Here's a submandibular, again, blue, coming from this signal. Then it arrives to the brain. Here's my MCA signal. So this is Dr. Chaltano, who was my research fellow buddy for a year. So he has the best photo with these dual transducers. This is how we are practicing on each other, and this is the best example that even without wires, you can still record some signals from his brain. And this is what it shows from the emboli shower from the submandibular to the transtemporal bone. This is how long does it take. So I would say this is like, I don't know, 3-4 inches, 15 centimeters, and this is almost like one heartbeat of the distance, and these are dots. So these are dots representing a second. This is like less than half a second from the submandibular ICA to arrive to the middle subartery. What's funny is that whatever goes up to the brain also comes down. So what you see here is a blue signal going up to the brain, and the red one, that's your IJ. So what you see here is a blue signal went up to the brain, and the IJ is filling up in the diastolic phase. This is why you know it's a venous signal, and that's coming towards your probe. So here your blue signal, there's no blue signal, but here's representing a red signal. So that's almost like you can time a cerebral circulation, if you will, time what time this bubble went up to the brain, if you can just inject just simple those bubbles, and you see when it started to come out on the IJ. I think this is really fascinating how you can time it, and again, just count them. Sometimes what was really funny when you are counting one going up, sometimes we see two coming out, 1, 1, 2. Who knows what happens under the pressure or under, getting a bubble into a bifurcation, maybe divided into 2 bubbles, and it was 2 bubbles coming out, why it's even just 1 bubble was going in. When we monitor the bypass, that's so much easier to see the microembol signal, because you don't have the pulsatility anymore. So when you don't have a pulsatility, all my AI buddies has easier job to find, here's a slow, here's a fast. So with the same speed blood flow, you can really easily differentiate, this is a big piece, this is a smaller piece. So this is how I'm using a little bit of sizing these. And again, almost I can see that when the signal is deleting, these are maybe a microemboli. These are the microemboli. So my microemboli signatures still remain white on the M mode, while you have black ones. Those are the microemboli signal, and what I'm hoping that hopefully they are not altering the waveform. So my criteria for this microembolus signal to risking an MC occlusion is that this signal is still flowing. So when you see that it's dipping down a little bit, it means that for a moment it's definitely decreased the blood flow here. Definitely decrease the blood flow going through that, so the speed of the flow is definitely altered in this waveform. While you have this microembolus signal traveling faster, there's no change on the waveform at all. So just study 1. Here is a slowly moving, really tiny one. 1, 2, 3, 4, and again I could decrease the gain a little bit more. But again, here it shows you that again not to trust sometimes the auto calculators. The A representing the machine is counting, miscounting 1. So again, a human counting at the moment is probably a better option. Hopefully we'll teach the machines to be able to recognize these 3, and that will be 3A underneath, similar to this, that the machine is counting them. And the counter is right up in this corner, would represent an automatic machine counting. Sometimes you have crazy signatures, and this is where you can see swirly, like almost like a turbulent or swirly signature. It goes up and down, up and down, up and down. This must be one embolus, but it's just going in circles and just having problem how it's getting more distal, but definitely is getting into the perforators, or did not travel all the way to the terminal part of the MCA. Why this signal is beautiful, nice and straight, goes all the way to the MCA. And these are the signals when you see again not connecting into the MCA. These are probably picked up from the ECA, from the external carotid. These two is represented by this ACA. So traveling all these microembolus signal, and this is what you don't want to see. This is a big piece of clot, and what it does is alter your waveform. This is 2 probe monitoring on the same depth. This is why you see it on the red and the blue signal, but the depth is opposite. So 36 here, but from cross-insonating, I'm also monitoring the same middle cerebral artery. So this is where you see that M-mode signal is definitely disappearing. Your spectrum here and it's gone. So this is a real-time embolus detection. Just a few more cases that how we are seeing this is again a 69 years old male patient with altered mental status, and looks like from this waveform that these are LVAD flow patterns. So this is not your normal arterial flow pattern in the brain. And after we see that, we gave TPA 1 milligram, and we followed up next day, no microembolus signal. So this is the power of TCD, that you really can follow, and you can see what you did. You definitely get rid of all those source clot, what was generated by those. But again, because it's LVAD is also metal, that metal also can generate some cavitation, some artifact. So when you see this many, you know that there's a source, and this is like showering, and every so this is 4 seconds. If it's 4 seconds you see this many, think about how many showers and how many emboli you see if you're just doing it for a minute or for an hour. Next case, 53-year-old patient. This is post-TPA, and post-TPA you still see the microembolus signal, tells you there's still something there. That is the clot. Maybe you are able to recognize the vessel, but you still see the microembolus signal coming from the carotid because going into the ACA. Concerned that you don't see too much recognition in the middle cerebral artery. So the middle cerebral artery signal is really minimal. So it looks like you still have issue with an occluded MCA. Another stroke, and this is where you see just one tiny embolus here. Maybe this is another one, but that one microembolus signal, because I'm monitoring the ACA, really hard to see. But this is again just one emboli is making any embolus detection study positive. So that's why it's kind of important. Here we're changing the depth, and while you're changing a depth, there's embolus sneaks in. So the embolus is between while you're changing a depth. This is the embolus. So you need maybe a microscope to look at it, but this M mode helps you to really see it, that is coming right there. And I think you're nicely seeing it with this changing depth. And what it tells you, this is again a left siphon. This is a reverse reverse ophthalmic artery feeding your carotid. So definitely it's interesting to know that with a total carotid occlusion, you even with your collateral still bringing up tiny clots, tiny microembol signal into the reverse ophthalmic to the ICA. So here's one, and unfortunately didn't pick it up, just barely, but on the M mode that you will just go back and monitor that signal a little bit more. I cannot read this one. This is also a stroke with with a hemorrhage, but also there was a PE with a filter. And again, I think the last line shows you the issue. So when we have cancer, we do have hypercoagulous state, and with those hypercoagulous state, you will see way much more embolization in the brain as well. And this is another example of how the microembol signal from one day to another just disappears. So this is a shower of emboli, and this is where next day you have nothing. This is an example. I want to. Oops, doesn't play. Oopsie, hold on. Doesn't want to play, but this is again a non-pulsatile LVAD signal, and this is a video that shows you when you have an LVAD turn on. You have the embolus coming. We turn the LVAD off, and you still have a pulsatile waveform. There was no embolus signal. Sorry, this video didn't play. The next case, my sonographer tells me that on this carotid system, there's two microembolus signal coming from this plaque. And I really looked at it, and I didn't believe it. And I think that's how I'm always investigating, that if it's coming from this plaque, I would monitor it somewhere here. Hard to believe that you will have an embolus coming here. So definitely these two, and I would sample it here. And what I requested is, can we do a bilateral emboli detection with a TCD? And then this is what we did, and we saw this machine with the P setting, and I will tell you in a moment what was that P setting. And we see one embolus. When we change the P setting, which is more than 3 liters perfusion by this Impala, we had bilateral microembolization. So it means that, and let me just show you what's the Impala. So going across the aortic valve, this is offloading the heart. And on the Impala, we had different P settings. So it depends on how many liters does it provide. And the P setting is here, P4. So when you have a P4, that is less than 3 liters. And with less than 3 liters, you have a beautiful, beautiful shape and pulsatile waveform. So increase more than 3 liters, you have no pulsatility, minimal, and you have microembol signal. So almost like you want to see the threshold when you're ICU, trying to find what's the best blood pressure and titrate that blood pressure. But in the meantime, you also want to monitor them, because it looks like above P7, you're risking multiple embolization. And this is again, if this is an 8-second screen, you see multiple emboli on both hemispheres. You're definitely trashing those capillary system with those. And again, this is in the ICU, left ICA, and again, this is your submandibular ICA, and this is your IJ. So what happens, sometimes you do the subarachnoid hemorrhage monitoring and a nurse injecting some medication. Get ready that some venous embolus signal you will appear, but this is again, you study it, this is not in my blue, this is not in my arterial side, this is on a venous side, it's a non-pulsatile, beautiful signal, but again, you just want to study the origin, want to study which waveform those microemboli signatures are sitting, and you see that this is not in the arterial side. So there's one paper I want you guys to find, and this is from Andrew McKinnon. He was showing us how monitoring can be like a Holter monitoring with TCD, just sitting with Dr. Esley created, and Dr. Esley created the very first TCD as well. A TCD just sitting on the glasses. But I think their discussion is very valuable. Their discussion was that if you're monitoring for, let's say, 8 hours, you're able to capture 70% of all these emboli signature. If you would monitor only for 15 minutes, look at this, 0. With 15 minutes monitoring, you would not capture any of these spontaneous emboli signatures, and these are coming from mainly from the carotid. So I think the take-home message, really the duration, how long you want to monitor for the spontaneous emboli signatures are really important. So again, these days, if you monitor for an hour, good. We need to probably extend it to monitor longer, that you will see more incidents. Then again, we just need one of those Holter TCDs, and that will help us to really define exactly how many microembolus signatures are really out there. So, and one more last slide for you, just to tell you that again, the timing is important. If you really time it closer to a stroke, then you will see definitely more. If you are monitoring a week later, you're not going to see those microembolus signatures. We were responsible maybe generating those symptoms, or part of the still lying clot source for those microembolus signatures. Well, in summary, I just would like to thank you for joining me. I do not see any questions, so I hope I wasn't by myself here in the studio, and at least one person stayed at this screen. And if you're not, we'll post this recording on YouTube, and I'm going to listen to my own lecture and listen to my own voice again. So in summary, I just want you to really remember the M mode is really crucial for your signal detection. And we did not talk too much about how you can measure the effect of the platelets, but trust me, if you give those platelets and we monitor before and after, you're able to see those differences in emboli count. And thank you so much for your attention. And one more time, join us June 11. If we are not getting at least 20 people registered, sadly, I'm going to cancel it. So if you don't want us to cancel it, please join us and register. Last year, I think we had 3,200 viewers. So if we have only 20, that would be a disaster. But so please join us for sure. Thank you again. Hello, my name is Zsolt Garami. I'm the Medical Director of the Vascular Ultrasound Lab at the Houston Methodist Hospital. We invite you to join us on Saturday, June 11, for our first annual Transcranial Doppler Master Class. It will be held in person and via live stream. As more information becomes available to healthcare providers through technology, our international reach also expands. We're honored to welcome our renowned international faculty who will join us for our first ever Transcranial Doppler Masterclass. On-site learners will receive hands-on training following in-person lectures. Remote learners will benefit from the high-tech streaming capabilities to fully engage in this experience. We designed this course for physicians, physician assistants, sonographers, nurse practitioners, nurses, residents, fellow students, and engineers who wants to master the basic of transcranial Doppler technique and its applications. You will learn from world-renowned experts teaching your essential concept and skills for transcranial Doppler topics. We tailor this program based on your feedback, requests to focus on TCD and carotid duplex. Our Vascular Ultrasound Master Class in November will continue to cover the rest of the vascular ultrasound application. Dedicated to TCD and carotid duplex specially, we'll discuss protocols, interpretations for vascular ultrasound application, blood flow pattern, and more. You will also gain hands-on experience performing ultrasound studies on volunteers and patients. By the end of the conference, you are ready to apply these techniques to improve your daily clinical practice. We hope you join us. Please register on website We are looking forward to seeing you in June.